seeing them in their time of serious illness. That these protocol-driven systematic solutions that I was called to implement and that I was graded on whether I was doing them was more important than me paying particular attention to the individual situations I was looking at, and that I was now involved instead of in this high stakes game of life and death, where my critical thought and my physical endurance and all those things mattered, and I was doing real work and energized to care for people. Now I was playing this financial game where I was trying to code properly in order to show in aggregate that our system saved money over time because I coded right and showed that everybody was really sick in year one, and then in year two we came out ahead of that. And all these, I didn't go into this to play these games. I don't know what I'm doing. I don't know. I lost my way, and I lost my soul. I just thought, how do I reconcile these totally divergent perspectives on what I'm supposed to do? And so I reconciled that by just deciding that maybe there are some doctors who can do all that at the same time. I'm not one of those, and I'm going to side on the side of my patients. And I'm going to go back to the way I thought I was taught to be a doctor. And how I actually did that and what I'm doing. Not that we're all works in progress, but I asked my colleagues the question. I don't think we're doing the work. I don't think we're the doctors we're supposed to be. And how do we get back to that? So I've been pursuing that for about, 10 years, 5 years in actual work through direct primary care, which we can talk about more, but it's not particularly about the model. Maybe you've heard that term, but it's a way of saying that I serve my patient, I don't serve a system. And systems are great, but I don't think that we are, I don't think that's our calling. Our calling is to care for people, and I'm trying to fulfill and refine my calling in my work. And far, that's a compliment. I just confused. There's we share a mutual friend in FAR. I just mistakenly called Brewer FAR, but Brewer has put a lot of good thought into some excellent questions that I want to allow him to ask so we can continue the conversation further.
Yes, sir. Yeah, sounds perfect.
I think I forgot to turn on my mic, but you all heard.
That's fine.
Okay, yeah. Okay. Should I turn it on now?
Sure.
Okay. Is that for the remote people?
Yeah.
Sorry.
Thank you. For sure. Thank you. We may have 25 minutes for questions as well, so we may not get to all of them. So I'll kind of jump on in. Maybe I'll start with this question, actually, the second one, before we get to Wendell Berry, because I think it tails on what you just shared with us well. It's a longer question, longer setup, long quote that's a part of the question. You sat on a panel with an intern in synthesis we actually just had last month in our Arete series, Lydia Dugdale, who's a friend, mutual kind of friend in the same group of people thinking about recovering a new way of medicine. One of my best friends, Ben Frush, he sat on that same panel. And then Dr. Bradford was actually at that panel too, so it was kind of weird, lots of connections, or attended the panel, so lots of connections here. You all spoke on the work of faithful presence in modern medicine, and my friend Ben, who's about to be a fourth year Vanderbilt Med Peds, wrote a powerful article around that same time called Suffering Absence, from which he largely gave his comments on that panel. He had in mind a term called suffering presence, which is what a theologian ethicist, Tower Wass at Duke, defines as literally the meaning and purpose of medicine, presence to the suffering presence. Literally in which you're proximal to pain, like you actually have to embody the act of being present but then also there is a kind of suffering that comes upon you as a physician to be present to suffering itself. Ben argued with a pretty heavy heart, and it's something he stands by today, that for residents specifically, suffering presence may actually be fundamentally impossible, and that maybe the point of residency training is not necessarily designed to form us to suffer presence. It's not to say that the end result is somehow bad or somehow worse than or somehow not good, but it does seem to be structured in such a way that kind of forms a suffering absence, a term that he kind of coined that's kind of taken off over the last few years. He writes, long quote here, but I think it's powerful. I'm just curious your thoughts. If you think he's too stark because he wrote this as an intern, or if you think it's kind of spot on, or if it changes over time. In the course of a typical resident call day, when the resident functions more like a cortisol-infused task manager than a thoughtful moral agent, two challenges to the call of suffering presence become apparent. The first is simply a lack of time. Evidence suggests that the average intern today dedicates more than 5 times as much working time on medical documentation, reviewing electronic medical records than in direct patient care. The forces that make this happen are sometimes subtle, like the hospital that requires large patient-to-resident ratios and daily progress notes to allow for prompt and accurate billing. Such large-scale bureaucratic and financial forces detract from the ability of the resident to care for the patient, creating a moral dilemma that has been implicated as one of the main factors contributing to the recently characterized entities of burnout, moral distress, and moral injury. At other times, this tension is made more explicit, such as when documentation of death takes precedence over time spent with a mourning family after death. The second challenge is that such a system lacks the ability to identify and thereby justify a response to suffering. The only way to complete the tasks required is a system that has clearly defined problems and solutions. Every good intern, I have my sheet in my pocket now, has a daily list of tasks with check boxes next to it, boxes that are decidedly binary and leave little room for any gray area. Every presentation and every note has a series of medical problems, the associated plan, and the metrics which indicate whether this plan has proven successful. Such a system induces a certain moral myopia, that there is no room to include issues like existential suffering on a problem list, not just because residents are not trained to view it as a billable medical condition, but because its solution does not lend to the clear, efficient measures taken with other hospital problems. There is a mantra in medicine: not to search for a problem when identifying it will not change management. The neglect of suffering seems to be an especially stark example of this. In the face of these two challenges, the structural barriers to providing presence become more apparent, and even if one were to find time, suffering is not viewed as a problem residents are trained to see, even less is it one that residents would be encouraged to address. Ben's a friend. I wonder if you'd say it differently now. He was in a dark place. But I look up to him in a lot of ways. And again, he wrote it as an intern, and ended his intern year. Is that too much? What do you think he's?
I think, I spoke about my residency experience a little bit just in the last year. So I finished my residency and then I became chief. And the year I became chief, part of my job was to enforce work hour rules. So that change happened right for me. And I don't look back with nostalgia at the way it was before necessarily. It was dehumanizing, as has been well described in other. I'm trying to think about. There's a famous book written in this about a residence experience in the '60s. Very, very cynical, but House of God. All right, you know the House of God, right? The House of God. There's always been more in most residency programs. There's the ratio of work and patients to residents has been bad, or has created a need to work faster and less thoroughly than would be ideal. And so I think that Ben is talking about something that is contemporary, but is also old in our system of training. And I think there's something to be said for surviving that in some fashion and seeing, quote William Osler, seeing much, hopefully wisely. That's how you learn, not just in seeing much, but seeing much wisely. I think I'm properly quoting him in that. I think the new, but I do think, to romanticize my just pre all this life as a resident, what was expected of me in that overworked setting was mostly clinical work. Yes, documentation, but documentation unto understanding and communicating the case, not documentation unto metrics, billing, coding, all that stuff that is much is onerous and bureaucratic and does not help us form our minds well around solving problems and thinking about things. So I think in my own post-residency experience, those forces are really pernicious and robot behavior inducing, that residents have always been susceptible to protecting themselves by hardening themselves.
Like a survival mode.
Survival mode. But I would rather that we all survive hard work and difficult situations going through pain with people than survive the bureaucratic rigors.
Let me, thank you. That kind of helps, because I do want to ask a question about both documentation and then maybe specifically about the crucible of residency and being formed in what is often systems-based bureaucratic care, and how that seems to be the normal path of training. So the first is the documentation one, and then I'll circle back and I guess ask the other one. You wrote 2 wonderful articles, haven't been published yet, but again, I think they should. What are doctors for, and then what is the good doctor? And I was struck by a line you quote from one of your patients who said, quote, "You doctors no longer see patients, you publish them," end quote. That line really haunts me because I love to write, and I find myself focusing a ton on efficient documentation. And I also think, too, of all the metaphorical weight of even the idea of being published, that to be published in the writing world means you have to be heavily edited, you have to be heavily formatted. There's literally a word count. We find ourselves cutting off and interrupting our patients. I find myself doing this in really clever ways that make it seem as though I'm not, but I definitely am. Redirecting things. You're such a good listener. It's like, no, I'm just trying to get you to move over here with me. So what is that patient picking up on? And yeah, you guys no longer see patients, you publish them, and yet we have to document in some way.
I think it picks up for me at my professional low point when I was trying to survive and do both, and when I was more succumbing to the pressures of documentation, which is to say going into the room and the patient is there and the computer is there and my focus is here and I'm typing and I've now, the way I work now is I'm not burdened with doing that, and I often get patients who are refugees from who have seen doctors who are forced to or find themselves solving their trouble by working in that way, and I remember many conversations I've done it, but also then hearing patients tell me, I went to see this doctor, I was there for like 3 minutes, and the whole time he was just typing on the computer. And I asked it, I remember one patient saying, "What are you typing over there?" What are you typing? And that is that's the patient experience. They see us in these time-limited interactions, spending an awful lot of time writing something that they don't know what it is, and they don't know necessarily the background that all this stuff is, everything that they say to us is being, sent and submitted to some other party, billing party that looks at it and decides if it meets criteria for certain codes and blah 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 blah, all that stuff. They just see us really doing something earnestly on the computer that seems to matter to us, and so I think that's the main thing that the patient is getting at there. And I remember another patient I recently saw who went to her gynecologist having a woman that around age 80 who had some pelvic pain and has a history of breast cancer and had some other concerning symptoms. And she came to me and said, I went to see the gynecologist and he typed on the computer a lot, and then he told me all kinds of reasons why there's no indication to do an examination on a patient my age, and I've never been to a gynecologist where I didn't have a gynecological exam. Anyway, and that's that was very again just distressing to me, and just thinking what's the harm that's been done to this doctor that tells him that he's not going to touch the patient who's hurting, who has legitimate clinical concerns that maybe you ought to investigate that. Anyway, I think that's part of publishing also, just worrying more about what you're writing and how it fits into this narrative than what the patient's saying and how you're going to respond to it.
Yeah, two. It just brings to mind two thoughts. The first is I'm thinking about this idea of touching patients versus sort of touching the keyboard and the computer. Not that they're mutually exclusive, obviously, but I'm a very violent typer. Is Spencer in here? I thought I saw him. He's told me many times at the end of all things, I will have to answer for the deep violence I've done to the keyboards. And I just can imagine a patient being like, I wish you would examine me with the level of, perhaps not that forcefully, with the level of intensity you touch your keyboard. You use Atlas, which is that narrative charting program, and it does, I don't necessarily we don't have to elaborate on Atlas. I'm sure there's other EMRs that do the same thing, but it does strike me that it's blank, it's just a sheet. And you've described other EMRs as being fundamentally an aesthetic of noise versus an aesthetic of clarity, which I guess something we could maybe circle back to, how the system itself is so noisy that it does make it hard to sort of, it doesn't suggest presence, whereas the blank page, you may make the argument, kind of does. It sort of invites a story.
Yeah.
I do want to ask this. I was trying to think of kind of steel manning the counter argument as deeply as I believe, and you know this, every conversations we've had. I just can't help that many of those engaged in the renewal of the profession, those like yourself, a few of our mutual friends like Far and Lydia, my dad, they all have, in a sense, paid their dues. Their careers, like yours, are marked by years and often decades in the trenches of insurance-based group care or whatever, like you, doing a kind of medicine that they've then come to lament and then seem to emerge 15 years down the road in a kind of new form of practice and presence. And my sense of the worry from critics is that going straight from residency to direct primary care or other forms of slow medicine, as Virginia Sweet called it, that I'm convinced by, that I kind of long for, skips over the very grit and sweat and stress and distress perhaps necessary to become a good doctor. That seems to be one of the counter-arguments. And perhaps the very faithful suffering presence we long for is actually shaped and formed first in the places where it is most difficult to practice it. Is this the great irony here, that there's something about medicine under the kind of bureaucratic pressure and data field management that is necessary to actually become a good doctor? Or is that just the voice of the kind of world-weary elder physician ossified within the current system?
Well, I think that I admire your foresight at recognizing the forces that distort the practice of medicine. I didn't have that foresight. I had to learn it by experience. I had to sort of live through doing what did not feel like my calling to find my calling, but I think in retrospect that I could have gone straight from my residency into being the kind of practicing the kind of medicine I practice now without being diminished. I don't think I became a better doctor during those years, and I would also argue, my wife would probably say the same. I think I work harder now than I did before. I work differently. I would offer no illusion. The work that we've chosen to go into is hard work, but it's good work. It's meaningful work, and it's so I don't think I'm underworked now, and I think we've now gone back to seeing patients in the hospital, so I do some of this stuff. I'm sure I can't measure up to your grandfather and your father and their toughness, but I go to around in the morning if I have hospital patients, I go to clinic, and somebody calls me at night, whatever, all that stuff. I have sort of the like the farmer's responsibility for the farm as opposed to the a shift worker's responsibility for what's happening on the assembly line while I'm there. So as you've already said, I think you have all of that difficult formation and wrestling that you need in residency. So I think before there was a world of medicine before insurance. Our profession existed before that, and for a long time before that, right? This is a new phenomenon. The way we work is new in the world. It seems like it's always been here because it's all we've known. But when I work in the way I'm working now, I feel like I have some touch with my forebears, much more touch with them, and they were hardworking people. So no, I don't think you have to do it. Don't go do it.
Thank you. I do want to circle back to the farming, and maybe we'll close with Wendell-Berry, even though it was the first question I had. I think I speak for many of us, hopefully many of us, that I hear something like this and I feel inspired and charged, moved. I think there's a sense of relief. I think one of the things I've enjoyed listening to you is there's a humility and a soft-spokenness, and you're actually doing it, and that kind of makes it more fun to listen to and perhaps more beautiful. But I was trying to imagine, I go to night float tonight, so this doesn't exactly apply, but I was trying to imagine that I'm going to go from this lecture and turn back to a busy day of clinic in which I'm going to stress about getting my notes done and getting home on time, in which I'm going to join my friends and complain about seeing patients and documentation at times. And it seems to me very easy to go from this place of inspiration in which we might consider other paths, other ways of doing medicine, or reform our training in some sort of attitude, and yet kind of having this sort of, this is just the way it is, man, and I got to put my nose back to the grindstone. And as you said, you can't practice good medicine in 7 minutes with metrics to hit. It's kind of tough for me. This is a tough one, but what would you say to those of us in training who feel that all we have is 7 to 15 minutes, and indeed have to turn from this lecture this very day and return to care and to training that we do not always enjoy?
I think I would hold as your banner in all things that I'm trying to be the best doctor I can be, and I'm trying to use the experiences I'm having here, the privilege I have of meeting patients in their suffering, to learn about illness, to learn about patient care, with the knowledge that the tools that you learn here can be used in other settings in different ways. I don't think I can lighten the burden of the present being hard, not just physically, but sort of psychically, in terms of what I experienced, the cognitive dissonance of I think I'm supposed to be doing this, but what I'm doing is this. And this feels bad. And I'm not honoring my profession in working in this way, but I think just that this is a crucible of time that you're going through as residents. Just be comforted to know that a la the house of God, it was always hard, and I think it should stay hard in certain ways to imbue us with the right ethics, and but I'd also say that there is a real role for imagination, and I would spend time with Brewer and in reading things. If you haven't read Francis Peabody, The Care of the Patient, who knows this article? Written in 1927 in JAMA, the Care of the Patient, and so when you read it, you'll say, oh, I'm not the first one to experience what I'm experiencing. And he talks about that the disenchantment that the American public has with doctors who don't seem to know how to care for people. They're technical people, and they're not, and that in residency training it's very hard to mimic. This is all in this article. How do you learn to care for people, but hold high the sort of banners that that people like Peabody have written, and I'll read a couple of excerpts from that. Now, this is in the summary concluding statements from Peabody's article. Now, the essence of the practice of medicine is that it is an intensely personal matter, and one of the chief differences between private practice and hospital practice is that the latter always tends to become impersonal. At first sight, this may not appear to be a very vital point, but it is, as a matter of fact, the crux of the whole situation. The treatment of a disease may be entirely impersonal. The care of a patient must be completely personal. The significance of the intimate personal relationship between physician and patient cannot be too strongly emphasized, for in an extraordinarily large number of cases, both diagnosis and treatment are directly dependent on it. And the failure of the young physician to establish this relationship accounts for much of his ineffectiveness in the care of patients. So know that difficulty of forming relationship is kind of is baked into residency, and but don't lose sight of the fact that relationship matters as you're learning the sort of the some of there's the art and the science of medicine as you're learning more of the science of medicine, and I'll read just a little further on further from Peabody. Disease in man is never exactly the same as disease in an experimental animal. For in man, the disease at once affects and is affected by what we call the emotional life. Thus, the physician who attempts to take care of a patient while he neglects this factor is as unscientific as the investigator who neglects to control all the conditions that may affect his experiment. The good physician knows his patient through and through, and his knowledge is bought dearly. Time, sympathy, and understanding must be lavishly dispensed, but the reward is to be found in that personal bond which forms the greatest satisfaction of the practice of medicine. One of the essential qualities of the clinician is interest in humanity, for the secret of the care of the patient is in caring for the patient.
Very, very insightfully.
Yes.
Dr. Brewer made sure that this conversation can continue tonight. We are out of time, and people need to, amazingly enough, go provide that care for patients. But I want to thank everybody that was involved in any of the processes, like phone calls, etc., to get us in the soap to completely fill. Tomorrow at 12 o'clock, we'll have a Zoom to see all of our new interns.